The AWARE project's aim is to balance the public conversation about psychedelics, spread accurate information, and give a new face to psychedelia. We feel that this change will occur through connection and relationship, one individual at a time. We are calling on everyone whose lives have been improved through the mindful use of psychedelics to educate themselves and become ambassadors for the psychedelic experience. Show those around you that people who use psychedelics mindfully cross all social, racial, economic, and political boundaries.
There was a very, 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 very exciting thing that happened yesterday. Yeah. Does everybody know what happened? For those of you that don't know, Denver, Colorado has decriminalized psilocybin. This is huge. I get goosebumps just talking about it. It's so huge, you guys. It's so huge. And I'm going to have Paul come up here. He's our video guy, and it has been with us for many years. And so he can talk a little bit about what happened, and then also what's going on here in California.
Thank you so much, Ashley. I don't know how many of you guys were following with anticipation Tuesday night, but it was quite a journey because they first posted the results for the election at 7 p.m. Denver time, Tuesday night. At that point, there was a 10-point spread between yes and no, and it was a no. And so it was very defeating. And then by the end of the night, the very last post at 1 a.m., it was only a 3.4% spread between the two. And news outlets were starting to report that it's failed. And then the next day, they were still counting. There was an article that said, wait, it's almost. And then at around, I think it was 2 or 3 in the afternoon, it came up with a final count, which was 50.56. Yes. Wow, it was totally amazing. So, and it's, as Ashley said, it's huge. It's more of a symbolic thing, you know. It does decriminalize just for the city of Denver, but it's a huge, worldwide covered situation. And California is also ramping up to put something on the ballot for 2020. We need a lot of signatures, over 600,000, and so it means we have to get close to 900,000. And tonight we have some official bling that you'll not see anywhere else. Decriminalized California stickers right there on the table. And right now, if you want to get involved, you'd have to go to the website and just sign up to be a volunteer. Because there's still ways, the language hasn't been approved yet, and it's in the early stages. The website is Decrim, DECRIM-CA.org. So decrimca.org. And there's a Facebook group also. So
Thank you.
Thank you so much.
It's a very exciting time to be paying attention to this stuff. Things are changing very rapidly. I am so excited to. I'll do an intro for Cole and Brooke a little bit first, and then I'm going to have Rachel come up. But Cole is my boss. He's the best boss ever. And Brooke is my coworker, and we have been. Sorry, I'm going to get a little emotional. We've been working so hard on these projects, and it's an honor to work with both of you and to be building this together. And it's so beautiful to be able to. I got connected to you guys because I started this, and it's grown so much, and this has grown so much, and it's just really amazing. So, yeah, it's been a lot lately. So, thank you guys for holding space. Yeah. It's something that's been coming up too, is that transformation with these things can be so quick, but transformation of our culture and of the laws, that's the long, hard work. And taking your inner transformation out into the world and making it concrete and staying grounded, that's the hard work. And so I commend the people that are doing this work, and we're all doing this together, and we're seeing changes. And they're happening faster than maybe we even expected. And we need to stay grounded and remember where we came from and where we're going. So, So I'm going to have Rachel come up. Rachel is a dear, dear friend, and she's graced our stage many, many times. She is an incredible poet and a mystic, and an incredible friend, and it's just an honor to have her back. So thank you, Rachel, and she's going to share with us some of her art.
I love you so much, Ash. I was wondering, I thought it would be weird because I would cry, but I feel very emotional too. I don't want to waste too much time. There's such amazing information coming to you tonight, but what an amazing time to be alive, where the stakes are so high and the changes are happening and it's so real and it's so scary and it's just so much, and I'm so grateful that our lives have intertwined. I am so grateful for you and the work you have done. I mean, I want to say give it up, but like it's such a gentle moment. I just like want us to feel like what you have. When we first met, this was a dream, it was a vision, and we were in a circle to create what we wanted to exist. And like, look at this, look at what you have created. I can't believe I get to be your friend. And the first time that I ever heard Cole speak, I was very moved. A lot of us, the reason that we seek a deeper exploration is because of the intensity of life. And we want to understand, and I share that journey. And this first piece I'm going to share, I wrote it a while ago, and I knew I would. I don't mean to be woo, but like we're all woo. Like it was furry. It was inspired. It was. I just thank you for the work you're doing, and thank you all for this. Like we're just in this together. When it comes to the subject of emptiness, are you hell-bent for leather? Is it a safe bet to say you're obsessed with that empty sensation? I'm saying, if you're prone to dissociation, put your frozen ghost hands up. Yup, that's what I thought. We got a full house full of haunted houses, and understand I add myself to that accounting. No matter where we go, when we collectively vacate our respective mental premises, our bodies always remain, are fully present for every second, absorbing each bit, faithful fleshly servants. So many sock puppets patiently awaiting fists full of animation. So many driverless cars, steadfast in the face of abandonment, tragically taking place right outside the filling station. We've been exhibiting the tendency to run on empty, to pretend the tank is full, despite complete depletion. needing to get our soul's vehicles cleaned, wanting to be windshield wipered from inside. We are in a complicated relationship with the void, both annoyed by and beholden to the whole and the whole. It's a constant push-pull with the gape and the fullness. Sometimes we're desperate to be vessels, no more, no less. Then we morph into vortexes of want, vacuums of longing. We venture into some pretty treacherous, troubled waters in search of that no-thingness spoken of by holy souls, sages, and madmen. We sail some dangerous seas trying to appease the grievous need. We are the beating hearts bursting forth from our own chests. And yes, it gets messy when just existing is considered disruptive. It's a pleasant enough suggestion to love the skin you're in. That is, unless you've ever let your flesh dance against the razor's edge. Unless you've ever been an emotional, bloodletting desperado wanting to dislodge the contents of what's deadlocked in your consciousness. Unless trauma has ever knocked upon your soul's door and been answered by an apparition. That is, unless you've got a head full of demons screaming for your attention and you'd do anything just to evict them. That is, unless you've ever wanted to check out when the pressure continued to mount, preferring any alteration to your mind state to the cold, hard slap of concrete reality against your cheek. That is, unless you've ever eaten your feelings for the cognitive knockout, the numb and stunned bliss of a donut binge, crammed down your throat like a rainbow-sprinkled, maple-iced iron fist of dumbstruck and delicious emotionlessness. The final frontier of our quest to fill the emptiness. See, you can live without booze, without drugs, without jumping up to make sure the front door is locked shut 100 times in a state of compulsion, without TV, without weed, even without dance, without prayer, without meditation, without creative visualization. Not that any of that is my recommendation, but the point is you can live without most anything. But, dearly beloved, we still must eat. Be still, my beating heart. The abject humility of this earthbound existence, of this abject barrenness, plumbs a depth that is endless, and the intensity is eerily transcendent, that it all goes pop, and we are lost in the awesomeness beyond the mere sensation of container, turned out, turned inside out, sprung, sweet freedom. Praise be to the vacancy, to the newly released, to the better than vessel, beyond the mere sensation of container, swimming in the liminal spaces, beyond reason, beyond thought, beyond what the no thing of time, space is not, where all that you've got are opposites to work with, the no thing of nothing, the not finite of infinite. Ugh. This description is a slippery fish, and not one of us has yet to get a better grip on it than this. Still, we persist at making valiant attempts from within this human condition. See, I stand here before you, a simple earthling constructing verses made of words, built of letters I've put together, but all they can do in their essential and ephemeral emptiness is point to whatever. For example, I could write moon in a swirling cursive with an old-timey purple plume, or a $1,000 fountain pen. I could graffiti MOON 10 stories high on the side of a skyscraper in the wild of the city night. I could just stand here behind this microphone and just scream, moon. But my mouth remains moonless. No luminous blue crescent issues forth from my lips. No yellow orb will spill from my tongue. Still, I will continue to croon my lunar tunes, compose my moon-eyed poetry, because don't you see, I got a lot of dichotomy going on in me and a little bit of wisdom, not a lot, but enough to know that within the poison always lies the antidote. Enough to know that there are treasures buried in the deep minds of our hearts' lives, which is why we continue to climb down the spiral staircase carved directly into the bedrock of our heart's most secret death wish, and keep going, knowing that this emptiness holds blessings beyond measure, knowing that this loneliness is holy, 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 wholeness. Thank you. Murmuration, it's breathtaking. Google it later. Don't Google it right now. Later. It's basically bird flocking quantified to the awesome power. It's starlings communing through flying and swirling like one transcendent entity. They move in a fluid choreographic flux on the constant brink of next shift, next shift, next shift, and each of these shifts is called a critical transition, a murmuration of thousands of starlings tuned into each other's movements through the phenomenon of scale-free correlation, each bird affecting the next 7 birds nearest to them, and then the next 7, and the next 7. Even Charles Darwin said survival of the fittest was a misapprehension of his findings. Even he believed in the holistic, was awed by the elaborate and elegant interdependence of nature. From abiogenesis all the way to present day, from subatomic particles to the entire biosphere, it's emergence that encourages evolution. Kill or be killed is a lie of the mind, an outdated paradigm, a flak jacket that can't keep out light. Let us take flight toward our final destination of wild and untamable kindness. The journey is long and travels forward and backwards in time. It's a bumpy ride, but the upshot is we can't not try. I'm speaking directly to the tiny little you who lives inside of you, reminding you of all the truth you once knew you knew implicitly. Returning you to your previous innocence, restoring your clarity, because kindness is your true nature, and I promise anything beyond that has been inculcated. As a matter of fact,
Separation itself is an illusion, doubly brewed in the hateful culture stew we have all been cooking in. And despite our desire to stay in denial, it's bubbling up to the surface. What I'm saying is, there's way more work for us to do. Don't get lulled into complacency by the fact that you feel compassion. Kindness is action. Not just that, kindness is actually a radical act in this hard scrabble and roughshod sneak attack of a life spilling with inner demons and double dealings. Kindness transcends mere feelings. It digs in the dirt. It's braver than hurled insults. It's rebellious enough to be vulnerable. It's vulnerable enough to rebel. Is confident enough to be patient, calls forth the great recalibration, an attunement to the sweetness that calls from within. If you're currently in life's trenches, please get this. Kindness is your best defense, your greatest defiance. This ain't rocket science. I don't care what your tribe is. The surprise is that kindness does not equal weakness. Actually, it's meanness that requires an Achilles heel to sting. Meanness preys on your insecurity, offers false surety, walls off and masks, distracts from the little voice inside whose calling for acknowledgement is needful of healing. All of this neglect and emotional starvation, treading crop circles so ancient upon your raw and bloody throbbing heart. Do not withhold the kindness that is longing to flow through you. In this very moment, you could choose to say yes. You could choose gentleness. Even though you like it rough, even though life's made you tough, in this very moment, you could choose to say yes. Who are you to discourage anyone? Yourself very much included. In this very moment, you could choose to be grace. Spin your suffering into endless golden thread. See the alchemy that awaits your bravery. In this very moment, you could choose to say yes. You could place your hand upon your chest. Upon your heart. Upon your throat. Upon your cheek. You could let that little voice within you speak, and this time you could listen. Give yourself the gift of presence. Let that presence warm like caramel taffy in your hand. Let it expand to include the person in front of you, behind you, to each side of you, and then the next 7, and the next 7, and then this whole room, and then this whole building, and then past all human, past all blooming, until your soul is a whole swarm of moonbeams filling this universe with your unique, super sweet, and deeply needed illumination. Thank you.
Well, we'll have Brooke and Cole come up and share with us about some of the things that we've all been up to over the last few years. And hopefully we have time to start.
Well, keeping in the same spirit, I want to acknowledge that I met Brooke at a Zendo project. Is anybody familiar with the Zendo project? For those who aren't familiar, it's a program that MAPS put together to offer harm reduction services at music festivals where people are often having difficult or their first psychedelic experiences and end up in emergency rooms instead of in compassionate hands when there's really no medical emergency to it. And so I met Brooke there because she's a leader of that organization for a long period of time. I met Ashley there, and Ashley introduced me to the AWARE project. So I came here as a medical resident when I was still in residency. That's how long this community has been going on. The first presentation I went to was for Vicky Kraft. Does anybody know who Vicky Kraft is? For those of you not familiar with Vicky Kraft, she's also an amazing woman. I'm surrounded by amazing women, which is by design. Vicky Kraft is an amazing therapist of her own. She's also the head of the Santo Daime Church, the Ayahuasca Church here in Los Angeles. And so I saw her presentation here at the AWARE Project, and so I just wanted to acknowledge Ashley that she's played a huge part in all of this happening. Vicky is on our study team. Ashley is on our study team, graduating to therapist, because since she joined our team, she's also completed an entire graduate program and so forth. And Brooke is on our team, and a couple other amazing people who aren't here, so they don't get any credit.
I want to do an acknowledgement. So our presentation is going to be in two parts, and the first part is goals. But before we begin the presentation part, I also want to acknowledge all of you guys, because this is a big group, many of who I've never met before. And I just want to thank you for taking the time out of your lives to come here, listen to the work that we've dedicated our lives to, and to me, that means that even before you know what we're going to talk about, you're aware of the power of psychedelics in the right hands, in the right set and setting, to change not only our inner selves, but our relationships and our communities. So thank you all for being here, and we're looking forward to sharing some information about how we got here today and where we're going next.
Yes, thank you. This, more than any other science project that I'm aware of, or any research that I've ever been a part of, is absolutely a community effort. Like, all of this research is being funded by the Multidisciplinary Association for Psychedelic Studies, which is being funded by donations, primarily from individuals like people in this room. So that's never happened before. There's never been, to my knowledge, and I doubt, that a drug went through the arduous process of becoming an FDA-approved medication for a nation that was funded by those people who are potentially recipients of it and not people who are going to profit on the back end. Or the government. Like, there's no government funding for this research. So thank you all for Thank us all. Thank us all. Okay. Let me go back real quick. I'm going to talk a bit about psychedelics as Western medicines, the history of them, because I think sometimes it gets lost that we're in like a derailment phase right now of actually a continuous process that started a long time ago. Has anybody ever seen this image before?
Yeah.
So his name is Tzovah, Tsili man, bee man, or mushroom man. So from what I understand, it's 5,000 to 6,000 years old. And so I just wanted to, touch on how long, at least I'm pretty sure that psychedelics were an influence on this artist. a start. Concrete evidence, or stone evidence. And then in early human history, all over the world. Listed here, shamanism has been well documented. Use of psychedelics, fly archaic, mushrooms in the Caucasus Mountains. The Greeks and the Eleusinian mystery, there's growing evidence that ergot and ergot derivatives, which are also the base for LSD, were a big part of ceremonies that took place in those societies. Central and South American, continuing to this day, use of Salvia divinorum, psilocybin species, ayahuasca. One of my hobbies is memorizing scientific names. Basteriopsis capii and Secotria viridis. Native American use of psilocybin, mescaline, and many others. And who knows who this is? Cheers! So, starting in Western culture, or more traditionally, conceived of as Western culture, Arthur Hefter isolated mescaline, the psychoactive substance in peyote and other hallucinogenic cactuses, and described its psychoactive effects. Albert Hoffman discovered LSD on Bicycle Day 1943, which is about a month ago now. Or Bicycle Day was about a month ago. A month and 73 or 76 years ago. And not a lot of people know this, that he was trying to make something that stopped bleeding, I believe, if I remember correctly. When he was creating LSD and all the derivatives that he came up with first, he was trying to make something that stopped bleeding after birth. It was a vasoconstrictor. And because of the actual, the other effects that it has on the psyche and the other psychoactive effects discovered, it's like a foundational reason that we, even in psychiatry, started looking at neurotransmitters as having effects on our mood, our experience of the world. It's almost, it's early in the foundation of psychopharmacology. All right. Now, who's heard of this place? Less people. That's what I was thinking. The Maryland Psychiatric Research Center, I was surprised to learn about. It was a research center, obviously in Maryland. From 1953 to 1976, they conducted 18 major scientific studies and published papers from there. Approximately 800 people received psychedelic treatment just in the studies that were conducted at this center. List of treatments, a lot of the same things that we're starting to reopen the investigation on now: alcoholism and addictions, cancer patients, and psychological effects of terminal illness. They have published papers in scientific journals lost to the dust piles of scientific libraries: LSD, DPT, MDA, psilocybin, mescaline, and Mdma. I'm not sure why I didn't put that up there. They had inpatient services, they had outpatient services. They were a fully functioning clinic on top of the research that they were doing. And they strictly worked with psychedelics. A lot of the remaining team are actually influencing or still operating in that region of Johns Hopkins. But had to go dormant in their academic lives for 30 some odd years. Why? Does anybody know who this guy is? Gordon Wasson is his name. He's a banker who was also, he's like a cartoon character in my head. But I can't think of a very good analogy, but in his spare time he liked to climb mountains and travel the world and get himself into crazy adventures. And one of them was going to South America and participating in a psilocybin ceremony. I think he also did a mescaline ceremony and came back in 1956 2007, and shared his experiences with Life magazine. And that was sort of the beginning, or that was a big part of Western culture's introduction to these compounds. And then I'm guessing most people know this guy. Timothy Leary started out in academia, obviously, and got involved in the counterculture, got fed up with academia, or academia got fed up with him, not really, depends on who you ask probably, and went off to do it on his own, to run his own experiments. I think they called it, I think it was Fallbrook. Does anybody here know the name of the place? What was it?
Millbrook.
Millbrook, thank you. Millbrook. Where he and late Ram Dass continued to experiment, but not in an academic or scientific kind of way. And let's see. You know, there was another kind of megalomaniac in this. Psychedelics, you know, connection to the countercultural movement had a large part to do with why it was shot down, derailed. Nixon was all about consolidating power. At least this is my interpretation. I'm sure he would see things differently. And so one of the people who he worked with closely to create the scheduling system and outlaw drugs later admitted that it was like more of a, they couldn't go after civil rights leaders for their thoughts because the darn Constitution, but if we outlawed the drugs that they take every day, we can go after them for that. And so that's how we ended up with marijuana, pretty much all the psychedelics, heroin, like, not things you'd think are on Schedule 1 are on Schedule 1. Cocaine is not a Schedule 1 drug. Methamphetamine is not a Schedule 1 drug. Alcohol is not a Schedule 1 drug. And then Reagan continued this spirit with the Just Say No campaign of the 1980s, and you know, a lot of miseducation. This is sort of the dark ages, you know, that the research at the Maryland Psychiatric Institute, which my fantasy is to recreate. So far, fantasy in action. A lot of that halted shortly after that, after Reagan created the DEA and the scheduling system. And that was culturally, you know, deepened under Reagan in the 80s. But in '85, they outlawed MDMA, and that sparked some rebellion in the people again. So some flickering light during these dark ages. We have 1985, the founding of the Multidisciplinary Association for Psychedelic Studies, which is a fully functioning giant operation now, but for 20 years it was just Rick Dolan with a business card that made it look very official. And so shout out to him. The Hefner Research Institute, the Beckley Foundation, these three have really been leading the charge for a long time. MAPS is primarily involved in MDMA research. The Hefner Research Institute has chosen to focus on psilocybin, and the Beckley Foundation, they're all supportive of one another, but the Beckley Foundation I think of as more kind of supportive of LSD specifically, and they're in England. So, the fantasy. The fantasy is right now 2 companies here in Los Angeles. New School Research, founded in 2017. We've been conducting Mdma-Assisted psychotherapy for PTSD research funded by MAPS in this beautiful setting. We are also just opened the California Center for Psychedelic Therapy. It's a bold name, we chose it on purpose. A lot of the idea here is to move towards something like once already existed, and that's what I really wanted to share with everybody. Like, if you've been profoundly moved by psychedelics, or you think you could be, you don't. The Bwiti tradition is beautiful, the Amazonian traditions are beautiful, but you don't have to change your entire historical background or orientation or paradigm for it to also be yours. That's all.
This for mine, if you can help. And while he's doing that, I just want to say, wait, I don't know what to do here. It's okay. It's funny that he says a fantasy, because every day when I go to work, it doesn't really feel like a fantasy. So it's pretty real. My name's Brooke Valiette. I'm a therapist here in LA. This is my lucky 13th year of being a full-time therapist, which means that I have done close to 20,000 hours of therapy. So, if you can still speak in full sentences after that, I feel like you should deserve a round of applause. But in all seriousness, I enjoy it a lot. It's only been in the past few years that I've moved into psychedelic-assisted therapy, and I did that because of those 10 years prior where I would sit with people who had severe depression, significant trauma, personality disorders, bipolar disorder, addiction, and there wasn't a whole lot of opportunity for them to change. So they could shut off, they could work very, very, very hard, or they could stay the same, were sort of the options. And so when it was really through meeting Cole and him sort of saying, oh, we're going to start this study, do you want to do it? I think I said, no, I have a job. And then a couple years later, I was like, hey, can I do that? No. And so now I do primarily ketamine-assisted psychotherapy in partnership with Cole, and soon to be Ashley, as soon as she graduates in a week. Yeah. And Mdma Efficacy psychotherapy through the clinical trials at the LA site of New School Research. And still some good old traditional talk therapy, psychedelic integration, and harm reduction, which are valuable in their own right. Psychedelic-assisted therapy is not for everybody. But what I'm here to talk to you about today is who it's working for, how it's working, and what it is. And so this is science. You know, I consider myself a scientist, and that's what I'm going to talk to you about, is what makes a substance a medication. Why do we call it psychedelic-assisted psychotherapy? Why are we sticking within the fields of medical intervention and psychological intervention and mental health? And so I'm going to just run through some facts. And then after I'm done talking, we'd love to hear thoughts from you and questions from you. And we're here to answer those questions. So there's a process that a substance has to go through in order to become used in therapeutic situations. Whether that's for diabetes or whether that's for trauma does not matter. There's primarily two government agencies that monitor that and make those decisions for all of us as US citizens. They're the Drug Enforcement Administration, which is was established in 1973 by our good friend Richard Nixon, who you saw in Cole's slides, basically who decided for various reasons that the government needs to be in charge of what we have access to. And also the FDA, and so the FDA has an approval process. So the DEA tells us through something called the scheduling system, which some of you may know. I'm going to walk you guys through it. I didn't know it very much. I'd heard the words, but I didn't know what it meant until I started working with these medicines. And then the FDA, so the DEA says you can and can't use these things in these settings for these ways. And then if you say, well, maybe I could, and you do the research to prove that you could or that you should, then the FDA, the Food and Drug Administration, is the one that decides. And you have to go through a pretty rigorous and expensive approval process that involves a lot of the research that some of us in the room are involved in, and millions of dollars. And so part of what we're using these days is because that process is in the process of happening or already has happened, and then there are other things on the horizon, but that process has not begun, so they remain unavailable to us. Then we can use drugs once they're approved by the DEA and the FDA in the way that it's like licensed or has been proven to the FDA to be allowed. So ketamine, for example, which we're going to talk about a little bit today, has been around for a long time. It's a really valuable anesthetic. And so it can be used for surgery, for instance. It wasn't until a few weeks ago that a derivative, or Cole knows what it's called, a part of ketamine called S-ketamine, was approved for depression. So everyone who is doing ketamine-assisted psychotherapy, even till now, who's not using S-ketamine, is using it off-label. And so what that means is that you can use the medicine once it's available to you, but you might not use it for what it's been indicated to the FDA as valuable for. That's totally legal. It's totally appropriate in the medical field and the mental health field. It's considered ethical as long as you're not using it to harm somebody. So as long as the people who you're providing it to are aware of the risks and benefits and that you're using it off-label, there's no problem. It's common across all areas of medical care. So let's talk about what it means to be scheduled. So controlled substances, which most of our substances are not. That's why we can buy things over the counter. A lot of the things that we use to take care of ourselves is not scheduled at all. They're like, you can have it, you just gotta buy it, and then it becomes up to the market to decide. But some of them are. And so there's 5 categories that the DEA decides in their controlled substance scheduling, 1 to 5. And they're based on basically 2 categories, medical use potential and abuse potential. So if it's on Schedule 1, which is the most restricted category, and that's where some of our favorite things, LSD, marijuana, and MDMA live right now, along with things that are pretty dangerous, like heroin, and not along things that are pretty dangerous, like alcohol, which is not there at all. It has been determined that it has no medical use by the DEA. So LSD right now has no medical use. MDMA, no medical use, in the process of changing. Heroin, no medical use. And so the potential for abuse is also high, according to the DEA. So you can hear right away, you're like, well, how did they decide that? That doesn't seem quite right to me. But that's what they tell us, and that's how we can get in trouble for using those. They've told us it has no medical potential, and it has a high potential for abuse. So we don't get to have it at all for anything outside of clinical research with people who have a special license called a Schedule 1 license. So if you're in a legitimate clinical trial and you're a doctor, you can get a license to be able to use that medicine, like MDMA, for the research, but not outside of that context. Then there's Schedule 2, where they have some indication for medical use, but also a high potential for misuse. So that's things like fentanyl, Adderall, OxyContin. Adderall is a great example. Some people really benefit from it, and a lot of people misuse it and abuse it. So doctors who prescribe Schedule 2 substances have to have DEA design controls that they have to conform to. So if you have ADHD and you use medication, a stimulant medication for it, you've probably heard or know yourself that you have to get a new prescription every time. Your therapist, even if you've had ADHD for 20 years and your medication is stable and you're just going to use it regularly, you're not going to abuse it, every time you need a refill, you have to go and get a new prescription. You can't get a refill like you could on an antibiotic or a lot of other medications, and that's because it's on Schedule 2. Then we've got Schedules 3 and 4, and so you'll see it just kind of goes down, so they get more useful and less abuse potential each schedule. So Schedule 3 is ketamine, and that's the first widely available psychedelic in the sort of current era that Western medicine uses. It's used off-label as an anesthetic, and then recently it's been given a new name with a slightly different formation called S-ketamine that's being approved and prescribed for depression. lots of common psychopharmaceuticals are also in Schedules 3 and 4, like Xanax, Ambien, Valium. Then Schedule 5, you have low potential, lower than Schedule 4, less addictive qualities according to the DEA. And then you go into the free world where they're not scheduled at all. And as you can see, it's important to think about those things. For citizens, it's also kind of arbitrary. And a lot of what Cole said has to do with why it is that way. And a lot of what we're working on as communities, as scientists and researchers, is challenging that and saying, but why? How do we know if something has medical potential? So how does psychedelic medicine, how does psychedelic-assisted therapy fit into all of this? I'm gonna go through 3 types of psychedelic-assisted therapy that are happening right now. The first one's ketamine-assisted psychotherapy. So you could get ketamine-assisted psychotherapy right now. You could leave here and call someone tomorrow and say, I want that for my depression, for my bipolar disorder, for my trauma, and you would be able to get it. And chances are it would be effective. Ketamine initially was a battlefield anesthetic in the Vietnam War because it's quick acting and it has pretty little side effects. Currently it's used a lot in pediatric surgery. It has a unique quality as a sedative in that it doesn't impact the air pathway reflexes. So for babies, for instance, it's a really nice way to do surgeries that doesn't make the risk of general anesthesia as high as some of the other anesthetics that are available. And it's been used to treat neuropathic pain and also depression successfully off-label for about 20 years at least. Cole's one of the first people to do it regularly here in LA. As a psychiatrist, there are anesthesiologists doing it here, and they're not doing ketamine-assisted psychotherapy, they're doing ketamine treatments, ketamine infusions, which is great, except that ketamine is a psychedelic at the levels that we use it for. So you can imagine if you go into like an emergency room setting and you get an infusion and you have a ketamine experience and you wake up and there's a nurse that has never used any psychedelics and she tells you it's time to go and you're still kind of like, okay. Can we talk about it? And so the reason that ketamine-assisted psychotherapy is rising in popularity is because of the combination of the inherent biological impact of the medicine on our nerves that changes our emotionality and our brain functioning, combined with the value of having a transpersonal experience. So having something that takes you out of yourself, something bigger than yourself, something that you don't understand, requires you to shift your perspective. So if you do that with someone who's trained to understand it and help you integrate it, the possibility of you healing is twofold compared to just getting the medicine. And that's what you're gonna see moving through this, is that these are psychedelic-assisted therapies that we're talking about today. It's not just the medicine, it's not the same when you do a big reel of ketamine at Burning Man. It's different. Even if you've done a big reel of ketamine at Burning Man and then had a really interesting transformational experience, it's still different to do it in therapy. It's clinically more effective, let's say that. So I'm going to show you, after I talk about each of the 3 psychedelics, I'm going to show you a little blip from research. So this is some data of ketamine-assisted therapy efficacy for unipolar treatment-resistant depression. So these are people who have tried lots of things to relieve themselves of their depression, and they are still suffering. So what you've got here are times. So from 40 minutes to the first 4 hours, 1 day, 2 day, all the way over to 14 days. The blue is a reduction in depression symptoms for people who had ketamine. And the red is a reduction in depression symptoms for people who had a placebo, a saline, without ketamine in it. So you can see that the blue lines are higher than the red lines, and that they stay that way for at least 2 weeks. This study was measuring 2 weeks. So we've got about 27% of people who feel a significant relief in their depression symptoms within 4 hours of their first ketamine treatment. And that rises up to over 50% at 2 days, and then makes the bell curve back down, but still is more efficacious than saline. So it's working, is what that slide means. And it's working a lot better than anything else that's available for depression right now, any other medications. Which is why the FDA approved Is Ketamine for depression, finally. The second psychedelic that I'm going to talk about today is MDMA. And MDMA-assisted psychotherapy is not available in the way that ketamine is. So unless you are a participant in a clinical trial, which in the US are happening right now at 12 sites in the US, 1 in Canada, 1 in Israel, you have to wait. Or you can choose to go in the underground, in which case you're not getting MDMA-assisted psychotherapy, even if someone tells you that they are, because as clinicians working in the studies, we're not allowed to do underground work. So if anyone tells you that they're a MDMA researcher and they're offering you underground services, they're lying to you, and you don't want to do drugs with them. Pretty soon, you will be able to do it, because last year, the FDA gave MDMA-assisted psychotherapy in the same protocol that's being used in the study, something called breakthrough therapy designation, meaning that the research from the last phase of studies indicated that the efficacy and safety is significantly higher than the other treatments for PTSD that are available right now. So similar to that ketamine that you saw, the graph that you saw, that mimics what we're seeing with MDMA-assisted psychotherapy. People are feeling a relief in their symptoms from PTSD. The relief is lasting longer than the MDMA experience, and the relief is significantly higher than the other drugs and interventions that are available. So both of the ketamine and the MDMA therapies are using a similar model of therapy that goes along with it, and it's called inner-directed. What this means is that as therapists, we believe that every single one of us, whether we're the therapist or the client, has an innate healing part of themselves that the medicine can help you tap into, rather than something like cognitive behavioral therapy, which has its place in the world. There's not like check boxes of like things you have to do throughout your day in order to get well using psychedelic-assisted psychotherapy in the way that it's being used in LA right now. The only thing you have to do is be able to attend to your inner world, your emotional world. And through that, you'll discover that you have the power and already the knowledge to take care of yourself in a new way. The medicines just assist that, because it can be really scary, like Rachel's poem, her first poem. Sometimes it's really dark inside, and it's too scary to look, or there's not enough light to look. And the medicine just allows a shift of perspective that people can see that there's things inside of there that maybe they can handle the things that they didn't know they can handle in a different way. And the therapist's job is to hold space for that and to assist the medicine in doing its work. So that's the style of psychotherapy, inner-directed. And, one thing I didn't mention about ketamine blatantly, but it's true for MDMA also, is that the recovery is not only greater from the symptomology that people are feeling, it's also quicker. So you don't have to wait as long. Therapy works for a lot of people, but it can take a really long time. And the MDMA and the ketamine-assisted psychotherapy, psilocybin, also allow us to not have to wait so long to feel a change, which just brings hope. It's hard to suffer for so long, and to hear you're going to have to wait however much longer it's going to take, which could be years, and dozens of thousands of dollars. So this is an infographic about Mdma Efficacy. This week, a new paper was published in, I believe, Psychopharmacology Journal, and they don't have a good infographic yet because it just got published, so I left this. But basically, this is from one of the 6 phase 2 MDMA-assisted psychotherapy studies. And what it's showing is that The black line is people that were qualifying for PTSD diagnosis before when they enrolled in the phase 2 clinical trials. 100% of people had PTSD. It's required to be a participant. The blue line in the middle are people who had PTSD. Oh, this isn't before, this is after. The blue line in the middle is people who had PTSD after the treatment when they got psychotherapy alone. So they had a placebo. So same as those ketamine people, they weren't sure if they were getting the medicine or not, which by the way, I realize sounds dumb. And if I had $1 for every time someone was like, but of course you know, you don't always know. And that's because of the satin setting, and it's because there's a lot of prep around it. And there have been people who have been tricked and they found out, and the therapists have found out, you find out at the end of the study who got what. And it's not as clear as you would think, I promise. So the people who got psychotherapy alone, they still had PTSD. Some of them got better, about 23% got better, but over 75 still had PTSD from just the therapy alone. That's still pretty good, and that's on par with other PTSD treatments. About a quarter of the people you could expect not to have a significant reduction in their symptoms and no longer qualify for the diagnosis. So that's not so bad. The therapy's not so bad on its own. But when you add in the MDMA, it went down to only 23%. So they flip-flopped. The conglomerate of all 6 of the phase 2 studies had a little bit of a different number. This dropped. This, I think they moved a little bit more towards 50, but still significantly higher than placebo. Over here is a more long-term outcome on the same study. So all those people before treatment had severe PTSD. 2 months after their treatment, it had dropped significantly, and then it continued to drop up to 4 years later. So for most people that feel the benefit of psychedelic-assisted therapy, they don't go back to their baseline, which sometimes is like a urban legend. It's like, well, as long as you're getting the MDMA, then you're fine, but then you have to do the MDMA forever. And that comes from, I think, those first things I talked about, is that that's how medicines have been for psychiatric disorders during our lifetime. It's like, well, you can either be sick or you can take Prozac forever. And if that's what you need, that's fine, but psychedelics are offering a more rapid response, short-term, effective treatment. Psilocybin-assisted psychotherapy is also available in clinical trials. It's just a little bit behind MDMA. But not too far behind. And so they're sort of neck and neck to catch up with ketamine about as far as accessibility. It also has breakthrough therapy designation from the FDA that just happened this year, or late 2018, for treatment-resistant depression. So they're currently enrolling trials all across the US. There's a few companies that are doing those, and they're using a little bit of a different style of therapy in their clinical trials called non-directive, where it's even less interactive with the therapist, but the therapist is creating a space for people to do their own work in partnership with the medicine and monitoring to make sure that they're safe. People who have treatment-resistant depression and anxiety we're seeing more efficacy with anxiety, or with psilocybin for anxiety, than with the other 2 so far. Well, I didn't even tell you, but you guys know that's the molecular structure of it, right? So this is some of the research for psilocybin. I can't remember if this was Johns Hopkins or Yale. Do you remember, Cole? Griffiths? Griffiths 2016?
That's actually NYU and Johns Hopkins.
Yeah, Johns Hopkins, I think then this is from. So they gave 51 patients with life-threatening cancer who developed end-of-life anxiety or depression. So they're like, oh, I'm gonna die and it sucks. And they got psilocybin or a placebo. So again, the gray groups are control groups and the green lines are psilocybin groups. So up here we've got improvements in depression, and these are all clinical improvements. They're measured by actual standardized measures in all of these infographics. It's not just someone being like, yeah, I feel better. Okay, good.
92% better.
Yeah, I feel like I'm like 92% better. So 5 weeks after treatment, 32% of the placebo group were feeling an improvement in their depression. Also still very good. That's pretty good for a short-term clinical trial for depression. Depression is not easy to treat, and 32% is a good efficacy rate. But if you added in the psilocybin, all other things equal, 92%, 5 weeks after treatment, felt relief in their depression symptoms. So something's going on with these medicines, right? And especially when they're in combination with therapy. 6 months later, that same group, 79% still felt a reduction in their depression. So a small group, as time passed, were like, oh, but I'm still gonna die. But they still didn't feel as depressed, most of them. Same thing for anxiety. 5 weeks after treatment, 24%, which is pretty standard for an anxiety treatment of any type. 76% when you add in the psilocybin. 3 times as many. And 6 months later, the anxiety symptoms continued to go down. More people felt less anxiety 6 months after they finished the clinical trial than they did 5 weeks after. And so again, to just highlight the fact that there's something going on that continues to go on, that doesn't happen with our other psych meds for the most part. It's at the beginning, for most of our psych meds at the beginning, once you get it worked out, you feel probably your best, but then they're likely to wear off later and you have to try another one. So something different is happening here. So there are other controlled substances that are exhibiting promise for the future, but we can't use them as medicine yet. So all of those clinical trials that I just showed you, the ketamine, the MDMA, and the psilocybin are costing millions of dollars, and they have huge amounts of people, administrative and clinical, huge agencies, including Heffter, Beckley, MAPS, NYU, Yale, Johns Hopkins, UCLA, these huge organizations that have the resources that are required. There aren't people in the US that have those resources that are yet doing the level of research to legitimize these as medicines. That doesn't mean that they're not having potential, they're just not down that pipe through our government yet where we can call them medicines that we're allowed to use. Hopefully they will be, if they show promise, which I want to highlight as well. I'm standing here today not because I love ketamine, I'm standing here today because it works as a medicine with the people that I serve day in and day out. Same thing with psilocybin, same thing with MDMA. And sometimes that's a misunderstanding that I know Cole and I get all the time. Like, but who is this? You know, someone's sister will come and be like, I don't know who that is. I don't think they're supposed to be doing that. That's an illegal drug. It's a recreational drug. It's not. Those are not. Those are medicines. These are still considered illegal recreational drugs at this point. We'll see what happens in the future. Like Ashley said earlier, things are changing rapidly. And the power of the medicines is undeniable. So we'll see where we go with them. LSD so far is having theoretical applications for alcohol addiction, withdrawal, and end-of-life anxiety, similar to psilocybin. Ibogaine is having preliminary evidence for opiate addiction and withdrawal. And these are from studies that have happened overseas, so not related to our government. And the way the FDA and the DEA work is if it gets approved in the US, it's likely to get approved anywhere else in the world should they pursue it, because our controlled substance process that I walked you through at the beginning is harder than almost everywhere else in the world. So if we get FDA approval, it's likely to be replicated around the world, but not the other way around. And then ayahuasca has some preliminary evidence for treating treatment-resistant depression. These are small studies, they're not well-funded studies, some of them are just case studies, which is a good sort of like, oh, cool, but we don't know if because it worked for one person, it's gonna work for 500,000 people or not. We have to measure that, broaden it out through all the phases of research, and then petition our government to reschedule it and approve it as a medicine. So Cole showed you this same picture. This is where we work. At the California Center for Psychedelic Therapy. We offer ketamine-assisted psychotherapy, psychedelic integration, trauma therapy, Jungian talk therapy. We're there day in, day out, fighting the good fight to get these medicines to the people that need them. And as soon as MDMA is rescheduled, we will be offering that. As soon as psilocybin is rescheduled, we will be offering that. And this, you're gonna see places like this coming up more and more as the years pass. And so just to give you a visual of what a mental health center can look like, it doesn't have to look like a lock unit, it doesn't have to look like the VA, it can, but it doesn't have to. And these medicines and their assisted therapies are taking us down that road. So, thank you. We have a website. It's Psychedelic Therapy CA. So while you're looking at Decrim CA, you can also look at psychedelictherapyca.com, and you can get all the information about our services, pass it on to people that you know that are looking for good therapy. Q&A?
Yes.
On the ketamine therapy, are you doing like an IV over time or IM?
Right. So, good question. And so, when I was in residency, I published, the biggest thing that I published personally was this huge review article on all of the too much stuff about ketamine. I have too much information about ketamine in my brain, so feel free to ask these questions. I compared single dose to multi-dose, intramuscular versus IV versus orally versus subcutaneous versus case reports of suppository. And so while there's more studies done with IV than there is with IM, intramuscular is the second most popular route of administration in the studies, and the efficacy is the same. So, the way that, it can be kind of, it's like there's more evidence that it's good for IV, but and there's almost as much evidence that it's just as good intramuscularly. And the intramuscular route provides it makes it less expensive because there's less complex monitoring than it would be given intravenous. And it delivers the psychedelic experience, which I've always felt was an important part of it. Giving it IV infusion over a long period of time, part of the reason that is utilized to minimize the unwanted psychotomimetic and dissociative side effects of ketamine. But I think that they're not unwanted dissociative or psychotomimetic side effects. And I clearly communicate that to patients, that this would be more like psychedelics if they've ever had a psychedelic experience before, and what that would mean and what that would be. So we do it, I am. Long question too.
Thank you.
Or long answer to a short question.
Yeah.
So I have a question regarding a two-part question. One, what's the earliest you anticipate that these would be able to be prescribed? And two, what would the process be for people to be able to prescribe them? Is it a therapist? Is it a psychiatrist? Does the underground become the above ground? And how does this work?
That's a great question. That's a moving target, and it's up to the government. Thank God for those research sponsors who are rallying with the DEA and the FDA to keep that process going while we're doing the clinical research. Hopefully within the next couple of years. Expanded access for MDMA is a different answer every day. And so I think I would like to optimistically say that by 2022, you should be able to go to our center and choose between MDMA and ketamine and possibly psilocybin. Also, psilocybin might be a little longer than that, or it could surpass MDMA. We don't know the details around that. It's totally up to the government. And same thing with the details about prescribing, but as it is looking right now, you would have to have something called prescribing privileges for MDMA. So you have to be a doctor who can prescribe medication. And for MDMA, you not only have to be a doctor that can prescribe medication, but you have to be a doctor who has a specific set of extra qualifications. So one of them with MDMA is being fully trained and certified to deliver the MDMA-assisted psychotherapy. And so there's proprietary rights around who will be able to prescribe it at that time. I don't know the details around psilocybin. I don't think they've been determined yet.
So as I saw Bert's slide on the ketamine and a sort of rapid reduction of symptoms, I'm wondering if it's ever used in conjunction with a traditional antidepressant that's going to take a lot longer to have any effect on symptoms.
Yeah, so there have been some protocols that have been put together with that in mind, because There were studies with citalopram, for example, as a SSRI, where the idea was that the ketamine would be like something to use until the citalopram came on. But it was, from what I remember, not really that different from what we would expect. Like, the ketamine was helpful for the same amount of people it would have been whether or not they were going to take the citalopram later. It didn't seem to like potentiate the effectiveness of the antidepressant. Like, it's a decent plan as long as both work still.
Sure. For esketamine or Spravato, the new nasal spray that you guys have heard about, it can only be prescribed as if it's only prescribed in conjunction with an SSRI.
Okay.
Priscilla, I know you touched on your opinions this in the first question, but I know the next phase of research for ketamine, people are looking at if they can isolate antidepressant effects from like the psychedelic effects, and if that would be a faster way to, I guess, integrate it into the medical framework. But I wanted to ask if you agree with that, your personal opinion.
So the question is,
If they're trying to isolate just the antidepressant effects and market.
right, without the psychedelic or dissociative
That's
effects.
valuable.
Yeah. There have been investigations into drugs that work similarly as far as the neurochemistry. For example, lamantine is a drug that is an NMDA receptor antagonist that doesn't cause these kind of side effects. There are a couple with like names that are letters and numbers because they're like on a spreadsheet that also were tried. Interestingly though, the NMDA receptor antagonists that cause some kind of dissociation, like ketamine, like dextromethorphan, and like nitrous oxide, all when tested to see if they help for depression have been successful. So I think that it may be possible to find something that doesn't have that side effect. And there are ways to really minimize it anyway. Like I said, giving the IV over a very, very long time can still have the same medical benefit. I don't think that the dissociative effect is entirely responsible by any means. I think I think it may be possible to find something that delivers the biological benefit without the psychedelic effect. I think that's a possibility. But with ketamine specifically causing both, I think you're missing a possible second opportunity for healing on top of the biological potential.
And I just want to add to that the medicine-assisted psychotherapy part too is important. People aren't just taking ketamine, having an experience or not, and then getting better. And part of therapy is having an experience, an emotional experience. So whether that needs to be psychedelic or not, maybe not. My professional opinion is that maybe yes, but we'll see, and I'll go with the science if that is proven wrong. But either way, having an experience is what's helping people heal, not just taking the medicine.
We should do someone over here.
What can you say about the quantities? I think we probably all look at these studies and wonder how much was administered, and what can you say about microdosing?
Is this on? Yeah, okay. So, I mean, the medicines that we're talking about here, ketamine, I mean, I don't think I've heard of anyone using ketamine to microdose. But the levels that we're using it at the clinic are like 0.5 milligrams per kilogram. So you're getting into starting to get into more of a psychedelic effect. But there are other researchers and other clinics that use higher amounts. But based off of Cole's research, this is an amount that is like kind of the bottom end of what's effective, and that's sufficient. As
in between, how I describe it to our clients is that for ketamine, it's in between a recreational dose and an anesthetic dose.
And then as far as MDMA, please do not microdose MDMA. Actually, people have asked me before.
Yeah, there was one study in phase 2 that had a low dose and a high dose. And the low dose people just got really irritated. Not to discredit that a really high dose of MDMA can be very dangerous as well, but microdosing for MDMA is not indicated by the research that's happened so far.
And it's, because it has some level of effect on your nervous system that's maybe not as, not as beneficial. It's not something you want to be taking. Also, the MDMA, because when you have it at lower doses with these low, kind of lower dose placebo, kind of lower, was that you're getting the kind of amphetamine part, but you're not getting the serotonin part. And so you're just kind of wound up.
For psilocybin, this study was full dose, not a microdose.
Which is what?
That's a great question. I don't know
So
the doses on
psilocybin,
that.
it's like a little weird because most people relate to psilocybin in terms of grams of dried psilocybin cubensis, and they're talking about like pharmacologically isolated psilocybin. So I don't remember the numbers because they're meaningless pretty much to everyone that you talk to, except for the people who did those studies. But what I've heard is that it's roughly equivalent to 3 to 5 grams of dried psilocybin cubensis, which in itself is a sort of wishy-washy thing because in psilocybin cubensis species there can be like a 10-fold difference between one mushroom and another. So, but it's like approaching a heroic dose, as Terence McKenna would say. It's a lot that they're giving in those studies. So it's intended to have a profound, life-changing experience. And in fact, when they did some retrospective questionnaires, almost everyone who had psilocybin treatment in that way ranked it as either the most important experience of their life or one of the 5 most important experiences of their life.
Hi, thank you both. Thank you all three. So you spoke about the need to have a medical license to prescribe, and so I'm wondering if you could speak a little bit about the role of LMFTs and LCSWs moving forward. And then sub-question of that is, I'm studying to be an LMFT and I'm in a transpersonally oriented program. So just recommendations as everything really rapidly grows and the need is there and growing for just pathways and how as an individual to therapists to navigate how we fit in and can fit in effectively.
So I'll be here for California. So what is the role of the therapist? Who qualifies to be a therapist in these types of therapies? And as a person in training as a therapist, what are some
next steps
or pathways to become a psychedelic-assisted therapist? So if you have mental illness and you want therapy, you should go to a person who has at least a master's degree in psychology or social work or marriage and family therapy or counseling. And not only should they have a master's degree, but they should be either licensed or registered with their board. So at the master's level, that would be the Board of Behavioral Sciences for counselors, LMFTs, which are licensed marriage and family therapists, and so licensed clinical social workers, LCSW. So there's 3 types of master level license that comes under the Board of Behavioral Sciences. You can go to the Board of Behavioral Sciences, bbs.gov, I think, or bbsca.gov, and you can look for someone's license. You can do a license verification. And if you're a student, you've finished your degree, but you haven't gotten your license, their name should still be there because if you're doing clinical work in California, you have to be registered with your board. So find out their legal name, go and look and see if they're registered or licensed, and they'll give you information about any malpractice issues or anything. If they're not, they need to be telling you that. And so nobody should be saying, oh, I have a master's in psychology, so I'm a therapist. No, unless you are registered or licensed with the appropriate board, you are not a therapist, no matter if you went to school or not. So that's the qualification to be a therapist in California. Also psychologists
too, is that the word therapy is a protected word. And so you have to be licensed to do therapy to provide therapy. So that's something that the lay public sometimes doesn't know.
Yeah, same for psychology and psychologists. So I'm finishing my doctorate in clinical psychology. I'm licensed as a marriage and family therapist with the Board of Behavioral Sciences. I'm finishing my doctorate and I'm registered with the Board of Psychology because I'm getting my hours to become a licensed psychologist. So the Board of Psychology is another place. If someone says they're a psychologist and they're doing clinical work of any type, but also psychedelic assisted, you can go to the Board of Psychology website and look for their license, and they should be listed there. If not, they're not doing therapy. Same thing for MDs, the Board of Medicine. Board registered psychiatrists are who you want to be working with if you're having mental health issues. There are anesthesiologists, there are ophthalmologists, there are gynecologists, which should be great if you need gynecology or ophthalmology. If you need mental health services, you should be going to someone who's fully trained and qualified in mental health. One last part to yours, you're going to see more and more training, internships, traineeships coming up. There's a great one in San Francisco right now. We're working on building one. So keep your eye out and just look for people. Make sure it's someone who can supervise you, someone who has supervisor qualifications from their board and has a real business plan that they're willing to share with you.
I'll add to that, for people that are mental health professionals or are wanting to kind of contribute to this work, even on like back-end administrative stuff, we are building like a database of people so that when we are ready to start hiring, we can go through that database and start to look for people. So and if you email psychedelic therapy LA, not CA, which is the website, LA, at gmail.com, you'll get an auto response, and then there's a form you can fill out, and then it'll get into our database. So
I think that form is going to be on our website soon too.
Yes.
And just to add to that, we have a lot of amazing therapists who want to do this work, and we absolutely understand why. That's why we're doing it. And there wasn't a path before. And our fantasy, I have so many fantasies. Part of that big fantasy is being able to actually list a job, like hiring psychedelic therapists, and take applications, and have interviews for psychedelic therapists. Actual job title on contract. So hopefully that is coming very soon. As far as that questionnaire, and if you are somebody who is not a mental health provider or a psychiatrist or in the medical field, those people we need the most. We don't know how to market things or operate things or get computers to work and appropriately do PowerPoint presentations. So if you want to help and you have any experience with anything, we would also like to
This guy way in the back's been raising his hand for like the whole time.
Thanks, Chris. Actually, I have a question for you. Just once you started practicing psychedelic-assisted therapy, what adjustments or changes did you notice in the way that you practice therapy?
That's a great question. Not too many. I think the primary one, the primary one is I am trained psychoanalytically, Jungian, and so I'm traditionally a non-disclosing therapist, which means if you ask me a question, I'm probably not going to answer it if it's about me. But that has changed because people are so wide open and so vulnerable that they're like, why are you acting like that? Where in actual therapy, they'll be like, okay, I get it, she doesn't want to answer the question, I'll just change my mind. So it's opened my heart more, I would say. I feel more open-hearted in session. I'm always honored to sit with people in their emotions, but I find that there's a little bit of a, contact high. And so it has helped me become more open-hearted, more empathetic, more patient, I think, than I was prior.
I have two questions. One, is this covered by insurance, and if not, what does it cost? And the other is, what are the contraindications if you have heart issues on MDMA?
So MDMA, the cost and contraindications.
The ketamine cost.
The ketamine cost is expensive. It is.
So we're the cheapest you're going to find.
Like I said, intramuscular was one strategy to limit the costs. The costs are listed on the website, but it's around $500 for a treatment with ketamine. That's with MD administering the ketamine and a trained psychotherapist integrating the experience. Something that
How many sessions are required?
so a single session works for about 53% of people, but for on average about a week. So a series of treatments twice a week is what I recommend based on the evidence. There seems to be a kindling effect. If you can have another treatment before any kind of downturn in your depressive symptoms, then that sort of launches a little further. So I recommend doing twice a week for 4 weeks, but I don't recommend doing that if it's not helping you. So for about 50% of people, the single treatment is helpful. For about 2/3 of people, a series is helpful, but the majority, almost all, both clinically and in the research, who respond to a series respond by the 4th treatment. So the 4th treatment we stop and we say, you know, is this clearly worth continuing, or is this just getting expensive? Also, the therapy portion is, I personally accept Aetna insurance, so I accept insurance for my portion of it, but I don't have across-the-board insurance. Unfortunately, right now, that would require that I hire some staff person to manage trying to get reimbursed.
Do insurers reimburse on this?
So not specifically, but they reimburse for a 90-minute appointment, which ours are 90 minutes. And so actually, when I take in insurance, I actually lose the ketamine money. I pay it for out of pocket because I'm just getting reimbursed for the 90-minute visit. And then, what was the other question? Oh, contraindication.
Two things quickly. We start any services with an intake, so a full medical history, psychological history, during which time we would discuss all of this stuff.
Yeah.
So in some sense, it's individualized, even though we have a protocol that we believe works best for most people. And then additionally, if you're interested in your insurance covering it and it's not Aetna, you can call your insurance and see if they'll allow us to bill as a out-of-network provider, which some people do, or some people use their health savings account or flexible spending accounts as well, so they can reduce the cost through that.
Yeah. And we will work with you to try and get reimbursed by your insurance, but more and more insurances are not offering out-of-network insurance, unfortunately. Contraindications for MDMA specifically. Absolute medical contraindications that's kind of what we're still discovering with the FDA approval process, but people who are excluded medically right now are people who have uncontrolled hypertension, people who have traumatic brain injuries in particular regions, having to do with memory in particular. Medically, nothing I think is an absolute contraindication. AFib would probably not you would probably not be enrolled in the study.
No, I'm saying when it gets legal.
When it gets legal, that's what we're trying to establish right now. We do cardiac, so part of the whole FDA approval process is not only proving that it helps, but answering all of those questions. So we get before the study starts, we get cardiac measures and we measure lots of other parameters to try and identify those kinds of things.
Are there any cardiac contraindications for ketamine?
Nothing absolute. Contraindication for ketamine Both would elevate your blood pressure transiently, like just while it's in your system, for about equivalent to like moderate exercise. So if you can handle a few flights of stairs, you should be able to handle it. With ketamine, no absolute contraindications. Cardiac, like I said, this is a moderate increase in blood pressure for about 4 hours.
Ketamine's a really safe drug. It's been on the World Health Organization's list of like most valuable drugs. It's safe enough to give to newborn babies when they're having surgery. So it in my experience, pretty remarkably non-reactive to people's bodies, other than their nervous system.
Criteria for referring patients.
I'm sorry?
The criteria for referring patients.
Criteria?
Mostly for treatment-resistant depression? Or?
Yes, for ketamine, it is treatment-resistant depression. There's also fair evidence for treatment-resistant PTSD. So the majority of the data, as with most off-label studies that are done, is with treatment-resistant XYZ, because that's how you start the research process. So people who have failed 2 or more antidepressant trials, either medications or therapy, like if they've tried 2 things, basically, is technically treatment-resistant depression. Treatment-resistant PTSD is the same thing. It's also helpful for bipolar depression, so not just unipolar depression. Doesn't seem to have the manic switch that is a risk with SSRIs or other serotonergic agents. So that's another, sort of holy grail that we've been looking for a long time pharmacologically, was something that you can safely give to bipolar depression patients also, because you don't find out a lot of the time that they're bipolar until you've switched them into mania on accident.
So I understand with Mdma assisted therapy that the client has an experience. They meet with the therapist before, and then they have the 4 to 6 hour experience, and then they integrate afterwards. I don't understand about the ketamine. You said it was 90 minutes, and then they have a psychedelic experience.
The ketamine part is about 45 minutes. So the way we structure our 90-minute sessions is there's like a pretty short check-in at the beginning where we knock off a few major things that we want to check in on from the last session, which, like we talked about, is usually only a few days before. And then we administer the medicine, and then the ketamine experience itself is about 45 minutes. Yes. Mm-hmm. And then they don't have to be, but they usually want to be. And then after about 45 minutes, we will help them remove their eye shade and their headphones, and then help them integrate their experience and do integrative therapy.
What is your vision on the future of ayahuasca in the Western world?
I won't speak for Cole, but I'll say we follow the research. So my vision is that it gets funding to get research to see what types of mental health issues it can resolve.
It's been trickier because it's not just a chemical that you can just isolate. And so it doesn't fit into our standard drug process, So, there are several churches that have gotten legal use of ayahuasca in the United States. So that's probably a more effective route for legalization at this point, is to go more of a religious freedom. But as far as the research goes, there's several studies that have been done in Brazil. But again, it's kind of seeing people or what the results are, people going to ceremonies. It's not like they're coming into a clinic and doing it sort of more.
Do you have a vision of what what things would be like with the ayahuasca?
Vision. Personally, I think that the religious freedom route, and to have it continue to be in a ceremony space, personally, because not everything necessarily needs to be medicalized. Some things can be ceremony.
I would just like to add to that, lots of healthy things are not medicines. Prayer is helpful. Ceremony without ayahuasca is helpful. Going to the beach is helpful. Eating better is helpful. Exercise is healthful. Yeah, lots of healthy things don't have to necessarily be medicines. But we have to be careful not to blur those lines on either side of the divide. Because we're talking about, not just, when we're talking about making something into a medicine in the Western medical model, we're not just talking about people who show up to the AWARE project anymore. Yeah. We're talking about people who've never heard of ayahuasca and don't want to hear ayahuasca, who just have depression and want it to get better. So we have to be careful of, yeah. I think it's a wonderful thing that has a bright future, but maybe not in medicine.
That's what I was going to say too.
I think we have time for one more question.
So with these trials and the FDA changing its mind that yes, there is medical use for these, where would you like to see the DEA have it rescheduled? Where do you think it might end up being rescheduled?
Probably Schedule 2. There's a contract in place guaranteeing that it will, that the FDA will officially recommend it as having medical benefit, or that it will be, that some action will be taken in that.
But do you think it will be 2 or 3 or 4? Where would you like it to be?
It'll probably be 2. I'm fine with it being 2 or 3. I think I envision it'll probably be like Suboxone or buprenorphine, where not any MD can just now start prescribing MDMA. They have to get additional training for this special medicine.
Just to keep in mind that even if MDMA gets rescheduled, it doesn't help your standard recreational user, So, there's a bigger thing here beyond just the medicalization, and there's a trajectory here that we're going on. We're using medicine, the FDA process, and the science to help introduce this concept of this into society. But, the whole conversation around criminalizing drugs and the freedom of consciousness and other issues like that, that's a bigger question. There are groups like the Drug Policy Alliance that are working towards the kind of the social aspects of drugs being criminalized. And so, I hope that, what we've seen in Denver is something that we're going to be able to continue to see more of, to start to experiment with what this could look like. But, I think we need to be careful because, our culture is new to this, and even people and we don't have elders.
We are
And so the people that are in this room, we're kind of the elders at this point because we've had more experience than the entire rest of our culture. And so we're in such a nascent phase of this emergent process that's going on. And we have to be aware of, these kinds of things getting in the hands of people that don't have elders around them to teach them. And I think that's what we saw in the 50s and 60s. There, at least we have the people that went through that process that can elder us right now, but they had no one, and that's why they turned to Eastern mystical traditions to help give them some sort of guidance. But waking up in the closed culture that was at that time, with no guidance, of course you're going to get a lot of kind of casualties. And so we, as a community that is emerging and evolving, we need to make sure that we don't make those same mistakes again, and that we, as I said in the very beginning, keep our feet on the ground as we move forward, and that we take care of each other and teach one another about how to connect to a different way of being.
Whoa!
Yeah.